Okay. So we're recording this so that people who are not able to be here either virtually or in person will be able to watch the recording at a later date. So yes, welcome to this first ever ARMA hybrid event. ARMA, for anyone who has not come across us, we bring together the patient organisations and the professional bodies in order to influence policy and care for better musculoskeletal health. So that's our purpose. Before we begin, this event has been made possible thanks to the support of our various sponsors. So I'd like to thank our lead sponsor, Simplicity. Please, if you haven't already had a chance to chat to them, do take the time to do that and find out what they do. And also thanks to our supporting sponsors, the Royal College of Podiatry, Society of Sport Therapists, the Royal College of Chiropractors, and the British Association of Sport Rehabilitation Therapists, BASRAT. They represent just some of the potential MSK workforce which can contribute to and help to alleviate the current work and contribute to the diverse, multi-professional healthcare that ARMA wants to see and believes is needed. So for today's topic, ARMA and our members are all very concerned about the inequalities, very definite inequalities in musculoskeletal health, and the inequalities in access to services. I'm not going to preempt by giving you information about that, the presentation that Liz will give. Now, Liz, unfortunately, can't be here today. She is demonstrating the importance of musculoskeletal health because her back pain means that she's not able to travel, but she will be joining us remotely when we get to the discussion. But before I give her presentation, I just wanted to say a few of the things that ARMA is doing to tackle these issues. So we did a round table last year, and you'll find that round table report on our website. We have created and are continuing to update a resource page, so curated resources that are specifically about musculoskeletal health inequalities. Very easy to find loads of stuff about health inequalities. Finding good stuff about musculoskeletal health inequalities is really not very easy. Tomorrow is the start of Bone and Joint Week, which is a week of raising awareness about musculoskeletal health. We have chosen to focus on MSK health qualities for this week. In your packs, you will find a little card saying, I support MSK health qualities. Those of you who are on social media, we would encourage you to have a photograph of yourself holding that up and to tweet it or post it on whatever platform tomorrow. Those of you who are online, we have similar resources available on our website that you can download, and I'm hoping that a colleague will be posting the links to these things in the chat as we go. Later this year, we will be launching a major national inquiry into MSK health inequalities, particularly related to deprivation. So I hope that you will all support that, that some of you may consider giving evidence to that inquiry. And then next year, we will be publishing that report and hoping that we can land some of the recommendations to make a real difference, because this is a really significant issue. But I'm now going to introduce Liz and Liz's presentation. She's pre-recorded it, so I'm hoping the tech will work. Although we don't seem to have screen sharing quite working here, but hopefully it's working online. So Liz works in system improvement for NHS England, particularly in North Eastern Yorkshire. She's also worked as an MSK physiotherapist and as a public health consultant. So those roles inform the work that she does now and how she does that. So I am going to just see, hopefully, if I can share Liz's presentation. Let's see if this works.
Thank you for inviting me to give this lecture tonight for what's the first in-person event for ARMA in over 3 years. And it's kind of ironic that due to sort of MSK reasons personally for me that I'm unable to attend in person tonight. However, I'm very much there in spirit and looking forward to the conversation that we're going to have with the panel discussion. I'm Liz Lingard. I'm transformation lead in NHS England in the Northeast and Yorkshire region. And this is just an overview of the approach I think we should all be starting to think about and consider as we really do strive to make musculoskeletal care more equitable.
Just to highlight the difference between equality and equity, I'm going to use this image here that just really highlights that when we're identifying inequalities in people's opportunities to access resources and healthcare, etc., we're using a tree with apples in this situation, we can see that everybody has different needs. And if we provided just sort of evenly distributed tools, there would still be people who didn't get the same outcome. And in this case, picking apples off the tree. So what we need to do when we've identified what the inequalities are is to customize tools that address these inequalities. So that's what we would call an equitable approach. Now, this isn't addressing the system inequalities that are present in our wider sort of communities and the wider determinants of health. It doesn't mean to say that whilst we're doing work to level up and make it a more just and fair sort of society, we can't be also turning our attention to focusing on equitable delivery of healthcare as well.
Within the NHS, there now is a national program that has the vision of providing exceptional healthcare for all with equitable access, excellent experience, and optimal outcomes. They have the 5 priorities that are there about restoring services inclusively, making sure that we're mitigating against digital exclusion, a big focus on ensuring data sets are complete and timely, especially with how we record ethnic.
So we can see if you can
we're just pausing the presentation until the audience here at BMA House can actually see the slides. So if you just give us 1 minute.
It's the joy of hybrid presentation. We've paused it because
That one's on, isn't it?
yes. The tech people are coming. So just
click
gonna,
on that one and see maybe that.
I'm just gonna
And play it from there. Maybe.
close that.
Who didn't get the same outcome, and in this case, picking apples off the tree. So what we need to do when we've identified what the inequalities are is to customize tools that address these inequalities. So that's what we would call an equitable approach. Now, this isn't addressing the system inequalities that are present in our wider sort of communities and the wider determinants of health. It doesn't mean to say that whilst we're doing work to level up and make it a more just and fair sort of society, we can't be also turning our attention to focusing on equitable delivery of healthcare as well.
Within the NHS, there now is a national program that has the vision of providing exceptional healthcare for all with equitable access, excellent experience, and optimal outcomes. They have the 5 priorities that are there about restoring services inclusively, making sure that we're mitigating against digital exclusion, a big focus on ensuring data sets are complete and timely, especially with how we record ethnicity, that we're accelerating prevention programs, and then we're really strengthening leadership and accountability. And this is not just people in very senior positions, but it's everybody at all phases of the organisation stepping up to take a leadership role for healthcare inequalities. The core 20+5 has 5 critical areas that aren't focusing on MSK at this time, But I think the principles of the core 20+5 are what we should be embedding into how we deliver equitable MSK healthcare. What's also good in the current climate is addressing healthcare inequalities, are part of the ICB aims, as well as the NHS really embracing this role at 3 levels as a commissioner and provider of healthcare, as a partner in these integrated care systems, but also as an anchor institution role and how these institutions contribute to the wider determinants of health.
So who is most at risk of facing health inequalities? We all know the protected characteristics because it's embedded in our equality, diversity and inclusion training that we all do as Statman training. But it's important to go further than this and recognise that socioeconomic status also plays a big part in terms of who is facing health inequalities. People who are living in more deprived areas are also more likely to live in poorer quality housing or overcrowded housing. They're less likely to have access to good income, as they might not be able to find work, or they may be limited in the work that they can do. There's a lot of people living in these areas now who are employed on 0-hours contracts, and they really struggle to have flexibility in their working day to access healthcare. And also these people have often had lower levels of education, so they really struggle in terms of literacy and health literacy. But there's a much wider group of people who also face health inequalities, and these are sort of the wider health inclusion groups that we speak about. So for this is people who are clinically extremely vulnerable, and in terms of the MSK community, these would be people with inflammatory arthritis who are on immunosuppressant medication, who had to shield during the COVID pandemic in the early days, and are still really struggling to come out and access face-to-face services as well. So we need to consider all these groups, and we also need to consider how they intersect as well. These factors don't happen in isolation, and where they all come together, they can really disadvantage people to actually really struggle in terms of how they access healthcare, but also the experience and outcomes they have following that care. So when we're considering the role that deprivation has to play, it also helps you get the context of the other factors that will affect how that person lives and works, and how that affects the way that they therefore manage their conditions when they're not with you in the home environment. So when we're looking at deprivation, we use these indices of multiple deprivation that ranks very small areas in England from most to least deprived, and it takes into account these wider determinants such as income and employment, as well as education, health, crime, and the living environment. So if we ranked every small area in the country and then split them into 5 even groups, nationally, you'd have a similar population in each group. But you can see here, if we look at who's living in those deprivation quintiles by region, this varies between the regions across England. And if you take, for example, the northeastern Yorkshire, where I'm from, just over 30% of our population live in these most deprived neighbourhoods. And within northeastern Yorkshire, we have wide variation as well that ranges from only 4% of people in York living in the most deprived areas to 55% of the people living in Hull who live in these very deprived areas. We also know that COVID shone a harsh light on the inequalities that we see that come from our ethnic minority communities, and that therefore led to a King's Fund report that looked at the health of people from these groups in England. And although it was considered that the access to primary care was generally equitable, it was less consistent in other healthcare settings. And we also know that people from ethnic minority communities often report being in poorer health and having poorer health experiences when they're using healthcare services if we compare them to their white counterparts. So there's a real need for us to understand what are the factors that are driving this, and to co-produce the services with these communities so that we make sure that they're culturally competent services. And one of the biggest issues that affects the access people have to healthcare and how they can engage with healthcare professionals is their level of literacy. And increasingly, as we move to systems that are digital by default, we know that some of those will be exclusive by design. So people are often quite shocked to see this slide because it shows that on average, just over 60% of the population in England finds written health information too complex. And this is a combination of sort of text and numeracy. And we know that there is a regional variation here as well, with people in the north tending to have poorer levels of literacy than the southern counterparts, with the exception of London, which has the worst overall rates for health literacy. We also know there's been real challenges around digital, not just in terms of people having access to devices, but actually being able to independently get on the internet themselves and be able to navigate the pages, to use the resources that are there. And there's an affordability element here if you're actually downloading apps or joining a Zoom class, for instance, where you have to use up data as well if you don't have contracts that are unlimited during this time. There is a real cost pressure on people. So a lot of these things aren't really affordable and accessible to our communities. And we know that there's a real divide between our most deprived and affluent communities. If you look at this, when they've done studies to look at how people interact not only with written materials, but also in terms of verbal consultations with doctors and nurses, you can see here that it doubles in the deprived communities, with much higher rates of them being able to fully engage with that information. But quite, a shocking statistic also to see that sort of 10 to 15% of people in our more affluent communities also say they have difficulty with written and verbal conversations. So why is this important for musculoskeletal conditions as well? And just sort of show this slide that highlights some very high-level sort of epidemiology of musculoskeletal conditions. First of all, these are really common conditions. Even though we think of inflammatory conditions and osteoporosis as being less common than things like back pain and osteoarthritis, when you put them up against other long-term conditions like COPD and diabetes, these are very common conditions. And we know the risk factors that are, documented to be linked to these conditions are very similar risk factors for other long-term conditions like diabetes and cardiovascular disease and COPD, for instance. And we also know that these risk factors are more common in our more deprived communities. So it's a perfect storm of knowing that these are conditions that we're more likely to see in our more deprived communities. As I said, they're very common. 3 in 10 people in the UK have musculoskeletal conditions. We know they increase with age and that they're more common in women than in men.
This slide's courtesy of George Peat and colleagues he was working with at Keele University, that looked at MSK consultation rates in sort of more deprived areas versus the less deprived areas. Now, this comes with a bit of a health warning. It's only as good as the data that's in the GP research data set. However, what we can see, if we're looking at consultations for low back pain, there's a 50% increase between the least and most deprived. And when we're looking at osteoarthritis, there's a 30% increase in consultations between the most and least deprived there. And there's quite a lot of regional variation with higher consultations in the north compared to the south. And this mirrors roughly what we'd expect the epidemiology to be of these conditions.
So it's important for us, if we're addressing health inequalities, that we take a life course approach with a greater focus on children and young people, what we can do to change those risk factors and change their behaviours so they have healthier lifestyles, so we mitigate and limit the level of some of the preventable musculoskeletal conditions as they go through the life course into working age adults and then into older age as well. And that we're also addressing health inequalities across the care pathway, from prevention to highly specialised care. So as a first contact practitioner, you'll see people presenting with mild conditions, as well as presenting potentially with undiagnosed inflammatory arthritis, where you need to rapidly get them into specialist services, as well as more sort of long-term musculoskeletal chronic conditions as well. So for all of these different ranges of conditions, we need to be thinking that we're always looking through a health inequalities lens for what we're doing to make sure that we are customizing the tools, we're customizing the treatment, the self-management support, everything that we do to make sure that we're addressing those underlying health inequalities. So if we are going to deliver equitable MSK health services, what we need to do is understand all the groups who are accessing services who are most at risk of health inequalities. So not just protected characteristics, also those living in deprivation or potentially remote and rural areas, as well as those wider inclusion health groups. That we take a population health management approach. So that's where you consider not just the people who are coming through your door, but everybody that lives in the catchment area of where your service is, so that you're thinking, are people coming to the most appropriate place for service, or are they accessing services in an inappropriate place? For example, we know that the activity in A&Es for MSK conditions is much higher for our most deprived communities than it is for the least deprived communities. Yet when we look at secondary care activity in terms of outpatients and going in for elective care operations, that difference almost disappears. We know the need's greater for people from more deprived communities, but it appears that they're presenting a lot more into sort of A&Es and things inappropriately. So it's trying to understand that, to think about how we take a population health management approach to redirecting them into more appropriate services. And it's really important that we co-produce this, so that if we're putting in place evidence-based interventions, we're making sure that they're going to be delivered in an acceptable, accessible and affordable way, and that we've considered all those other factors that I've spoken to you about, health literacy and digital inclusion, etc., and that we're making sure that they're culturally competent services. And this may require us to unequally weight or target the services, because what we're looking for is this proportionate universal approach. So there's a universal offer, but it's proportionate to the needs of the community or the population that we're serving, and that if we have got these specific groups that we know are at greater risk of health inequalities, that we're targeting the interventions to them as well, or we're putting in additional support to help them engage with what might be digital tools or other sort of patient management tools that are written materials. We need to make sure that we're doing some public-facing comms, and again, we co-produce these with the communities as well. And none of this has to be done in isolation or on your own. There's lots of people working in the NHS in regional and local teams, as well as public health colleagues, either in the what was formerly Public Health England, now as the Office for Health Improvement and Disparities, and local authorities and our wider partners like the academic health science networks, who are there to help if you don't fully understand these issues, to help to co-design these services.
I think it's important to also reflect on what we can do as individuals, as a member of a team and as a member of an organisation to really reduce health inequalities. I think this is the only way we're going to challenge ourselves to create the optimal sort of environment for this to happen, so that we really are constantly reducing health inequalities by really listening to those who've got lived experience to help us find these solutions. And for those of you who are listening or know people who have had experiences where they have had a poor experience of care because of an inequality that they have, really keen to hear those stories, so that whether it's an individual or family or friends that have experienced this, or a wider community, it's very important that we find safe places to hear these stories and use that to co-produce solutions. So before we embark on any decisions and how we're going to move the agenda forward, there needs to be that time where we take the time to ask these questions and have this discourse. And this is sort of part of what's happening tonight and shaping what happens in the next 12 months as well, to make sure that what we're doing isn't inadvertently widening health inequalities as we go in our ambition to reduce them. just wanted to also pop in that sort of King's Fund tool. I think it's a great tool just to give people the basics. I know it's been developed for allied health professionals, but it really does have some great, very simple advice on how to raise awareness with individuals, how they can take action, and how they can be an advocate, regardless of what level in the organisation they are. So really now it's a time to sort of get involved and make a pledge to listen, learn, and level up. Would be great if people were pledging to do things today that will help make a difference. If they're already doing great work, then shout out and let us know so that we can share it. And if you need help and support and want to link in with people and network, again, we want to help make those connections. And this is a real opportunity to do that with a fantastic organisation like ARMA to support you. Thank you for your attention.
Brilliant. Thank you very much for that presentation, Liz. And thank you to everyone who has stuck with us through our technical problems. I gather some people online have had difficulties in hearing the presentation properly. We'll make sure we post one online that is that you can hear. So we're now going to move on to Q&A and a panel discussion. So Liz will be joining us. Liz is joining us from Newcastle, and I'm joined on the panel here by Asim Suleman, who is a GP specialising in pain management, an occupational health physician and a versus arthritis champion, and also by Jane Taylor, who has spent most of her working life in education and now works for the Open University. She was diagnosed with rheumatoid arthritis at age 26. She's involved with NRAS, with versus arthritis, and I'm really not going to list all the various projects and committees that she chairs or is a member of, because we would be here all night. So before we move to Q&A, so people who are online, please post the questions in the Q&A box, and you will also be able to upvote each other's questions. People in the room ask questions in the usual manner by sticking your hand in the air. But I'm just going to invite Jane and Asim to very briefly respond to what we've just heard. So, Jane.
Thank you, Sue, and thank you, Liz. And I think Liz has highlighted so much in that presentation that we could probably talk about each slide for several hours. So it's hard to be brief. But a couple of points I would say. I think as a long-term patient with several autoimmune conditions, but most affected by inflammatory arthritis, I really like that first slide, and also because I'm a carer, where there was that distinction between equality, equity, but also justice. And I think it's very difficult at the moment. We're not in the best of times economically, and it's very difficult, I think, to hang on to how can we make healthcare more equitable when the justice aspect seems to be going the other way. And I think we have to be very creative about that, and we have to try and be positive about that, although it's hard. But I think we can't underestimate that level of structural inequality that justice represents. And I was reading, and many of you will have seen in the press, the study that came out last week from the University of Glasgow, which looked at the excess deaths caused by austerity. And it's over 300,000. And if you think about it, to put it in perspective, there were more deaths in the 5 years pre-COVID because of austerity than there were in the first 3 years of COVID. So it's quite a shocking statistic. And of course, they're not spread equally. So after, a couple of decades of actually mortality going down in some of the most deprived communities, we're actually, in the process since 2012 of that going backwards again. So I think we can't underestimate the job that everybody in healthcare has to do, but I think it's important to try. So I was really, really glad to see that. The other thing I was really glad to see in Liz's talk was the importance of the interrelationship of inequalities, that we're not just our gender or our ethnicity or our religion. or our social economic status. All these things interact together to determine our experience of healthcare. And I think it's really important that we see that, and that we see how complex inequalities are. So if you are in a good position economically, that won't stop some of the issues that you have in terms of inequality if you're a member of a minoritized group, but it might ameliorate it to some extent. So I think we have to be, very, very aware of the complexity of that. Lots and lots of things there. I think very important to think about health literacy, and, quite a shocking statistic there. But again, even with that 61%, we know that within that population, there is a big divide in health literacy, and there's a big divide, of course, in digital skills. And I could talk about digital exclusion all night, because it's something that really bugs me and really affects me and has affected me, particularly over the last few years. But I care for someone who has schizophrenia, and as well as physical health problems. He would by all measures be seen as in some of these lower groups. He doesn't have access to a computer. He has a mobile phone, but he'll only turn it on if I tell him he has to have it on at this particular time. He could not cope with the triaging telephone appointment that goes on now. He couldn't get up at that time because of the drugs he takes at night time. And the whole idea of being put on hold, he would just say, well, there's people worse off than me, obviously. There's 64 people in the queue before me. They must be really sick. I won't stay on. So I think we have to be aware of just that digital exclusion on every way, not just the lack of digital literacy, but also the access to those kind of, everyday things that society is now beginning to take for granted. We have this kind of digital first creep. And we don't know who many of these people are, because we're not hearing from them. They're not getting into the healthcare system. So, I think we have to be very aware of that issue. Very, very pleased to hear about co-production. I think co-production is the way ahead in all aspects. I think we have to listen to the people with lived experience, and we have to do it right the way up. Not just at the bottom, not just inviting a few people to get involved in a project, but we have to do it from the top down. We have to have lived experience with the people who are directing policy, who are determining policy. We have to have lived experience on all those important boards, because only by doing that will we really understand how to get the right policies and really help shift this inequality that we see. A couple of other points. The last one, the one I would disagree with, I think I made a note here that Liz was saying people were using A&E inappropriately. And I know that Liz wouldn't, that's thinking about inappropriate pathways, not higher language. But I have to say, I think we have to be careful, because it may be inappropriate in terms of a designated pathway, but it may be appropriate for them at that time. I mean, I think about my own experience when I was really struggling with rheumatoid arthritis and didn't know what I had, and was in a new city in my 20s. And I ended up going to A&E because I was getting nowhere with a GP. And it was only because I went to A&E and just really refused to go that within a week I was in a hospital bed. Within 9 days, I was having an arthroscopy. I got to the right place. And I was hearing, or I was listening last week to a young woman with lupus, a recording that she'd made for Lupus Awareness Month. And it took her 9 years, a young Black woman, to be diagnosed with lupus. She went to a GP constantly in those 9 years, but she was constantly gaslighted. She was constantly told it was, it's just, stress, it's other things, you're tired, you're run down. She lost 3 stone in weight over that time. She had constant infections. It was only when she went to A&E, made a fuss and refused to go, that she got an appointment. She was diagnosed right away. So I think we have to be careful of assuming that certain behaviours are not appropriate. They may be the most appropriate and the best behaviour for the patient at that time. But lots there to talk about. That's just some of my thoughts on it. Could talk about it all night, but over to Asim.
Thank you, Jane. And thank you, Liz, and good evening to everyone. So I just wanted to kind of bring it back, I guess a question for Liz being NHS transformation lead for my area up north. I come from Bradford. I was born and bred in Bradford. I work in Bradford. And Bradford's a mixed place. It's I think the 5th biggest metropolitan district in the country. And at one end, you've got places like Ilkley, Betty's Tea Room, yeah? Drive 40 minutes and you're into the heart of Bradford, probably one of the most deprived in the country. Yeah. So within metropolitan districts, there's inequality and inequity. Looking at healthcare, there has been data, there's been robust data over the last 20 or 30 years from the David Wanless reports, from the Professor Marmot reports. And this all fits with what Liz has talked about today. My question, I guess, to Liz and to the wider audience is, what are we going to do about it? Yeah? Are we going to be sitting here in 10 years' time talking about the same facts and figures? Yeah? How are we going to instigate that real change to make a difference to our populations, whether they are in Ilkley, but more likely whether they are in the heart of Bradford or Tower Hamlets? Yeah, what can we do about it? And a question I guess added onto that is, the NHS, from a primary care perspective, was on its knees before COVID. Yeah, COVID has brought into sharp focus some of the issues regarding access to general practice, regarding wait times in secondary care. Do we have the resilience in our workforce to carry these changes through? And that was just a question for Liz.
Thanks. I think that's a big one for me to answer about for the NHS as a whole. But I think the good thing is there is now a national program led by Bola Walabi, where they are, very much focused on getting people to think about this across all areas of healthcare as well, and not just about the people who are accessing healthcare, about the people who we think aren't even coming through the doors at this point in time. But rather than go on with a long ramble about it, because we do want to hear from the audience as well, I think we do need a culture change though. So we need the frontline teams, and not just clinical teams, but admin teams as well, to understand what the issues are, who's at risk of facing a health inequality, and to think beneath that about how we can make our services more accessible for them coming through the door. The workforce issues are a big problem, but we've got to get smarter about how we work. And I guess when I was saying people were going to A&E inappropriately, I was meaning they're not going to get onto the elective care pathways through an A&E service. And it's also a chaotic and unpleasant place to go if you've got back pain or something like that. So it's thinking about how do we take pressure off places which aren't appropriate for people to go for treatment. We make it more attractive and accessible for people to go to places where they will get the right treatment and they'll get on the right pathways and get the right support and wraparound care going forwad. But I'll pass back to you, Sue, because I know we're short of time and I'm sure there's lots of questions from the audience as well.
Yeah, so we'll maybe start with a question from the audience in person, and then we'll try and switch between the two, but also I'll take questions, but I'll also take any responses to Asim's very valid challenge, which is, we know what's happening here. What are we collectively, all of us, going to do about it? So anybody who'd like to ask a question or take up Asim's challenge, try and answer that question. Yes.
My name is Laura. I'm asked to ask a question about fracture liaison services. The access to fracture liaison services and the quality of fracture liaison services vary a lot around the country. We know that they're really helpful and they reduce future fractures, but how do we ensure that while we integrated care boards prioritise the commission of fracture liaison services so that the inequalities in secondary prevention can be addressed effectively?
Okay, so just in case the microphone didn't pick that up, questions about fracture liaison services and the fact that they are available in some areas and not in others, creating inequalities given that we know how effective they are. What can we do to try and address that inequality? Anybody want to have a go at that? Liz?
So I think, part of this is it's not just about fracture liaison services, it's even things like the first contact MSK practitioners and all sorts of initiatives that come in. They're not really strategically thought out about putting those services where the need's the greatest. So if we can really take that approach that I outlined, where we're thinking of who's going to face inequalities, we're using a population health management approach, and we co-design the services to make sure that they fit the needs of those communities and those populations. So although the question was specifically about fracture liaison services, I'd say it's valid for any service that we need to put services where the needs are greatest, rather than it just being a bit of a free-for-all when money becomes available. And that definitely is what's happened with some of the first contact MSK physiotherapists who've gone to more affluent areas. And we know that in areas that are more deprived, where they've got real challenges, they've struggled to recruit there. So that would be my sort of response to that, Sue.
Brilliant, thank you. There's no compulsion for everybody to answer every question, but did either of you want to add anything to Liz's answer?
No, that's fine.
You wanted to come in on that particular point?
It's to take up Asim's challenge.
Right, okay. Go for it.
Well, I'm not seeing the hand.
Yeah. So I'll invite you to do that, and then I'm going to take a question.
I'll keep it very brief. I think, thank you to everyone who's spoken so far this evening. The big challenge is how we really raise the profile of prevention and how we perhaps go as far upstream as we can into looking at maternity health, child health, and look at the social determinants of health. Healthcare is the delivery model in which to deliver health, and yet we are constantly dealing with the challenges of not addressing education, literacy, health literacy, financial stability, safety, safeguarding, etc. So it's a big challenge, but it's one that the Secretary of State for Health and Social Care should have with their allies in education and in housing, and really whether political landscape can wait that long to see the benefits of that approach. But I would say that if we can begin to look at those wider determinants of health and start with education and housing and the ability to support our workforce to generate their own well-being, I think we can then begin to address the reality of today, which is dealing with the fallout of ill health due to those social determinants. It won't happen perhaps in the next 5 years, but if we are taking a long-term view, that's where I would suggest we all collaboratively need to work, and with our lived experience partners always present.
Yep, and certainly prevention is something that I've talked about a bit. I've said we need to stop trying to build a bigger bucket and actually fix the leak. But I don't know if anybody wants to respond to that. It feels to me a bit like it's another challenge like Asim. We all know that prevention is the best way to do it, but we just don't.
I was just going to say, I mean, I think that there is absolutely, it's a massive challenge, and a lot of it will be outside of NHS control. It will mean involving other partners, public health, education, local authority, central government. And even looking at things, like you said, going back to childhood, things like adverse childhood experiences, where we can have that input because we know it impacts on long-term conditions. So it's a case of working differently and involving local communities and our public health partners as well.
And I think also listening to the patient, because I think that the difficulty we have at the moment, and I feel this as a patient and a carer too, is that there is so much emphasis now when there's so little time and GPs and everybody is under stress to just focus on the functional, take the pill, fix, oh yes, right, your blood tests are better. rather than to kind of come back to, the World Health Organization definition of health, not as absence of disease or infirmity, but as, kind of living with the best physical, mental, and emotional health. And often, patients talk about what is really, what's really getting to them about their condition. And it's often not what the doctor is measuring. So often it is about how it's affecting other things in their life, or how other things in their life are affecting that. So I think we have to really, come back to that wider definition of health and listen to the patient all the time.
Right. And Liz, would you like to come in?
Yeah, and I think that's great. I think the personalised care approach is starting, but it's not embedded, but there is an opportunity to really push that. And I'd just say about the prevention aspect is, MSK conditions are a big cause of days lost for work. So starting with our workforce and educating them. So we're educating children, but we're educating the workforce as well to keep them healthy and strong and get them back into work. But it sort of should become something that is much more holistic than, your basic sort of statman training that's about lifting and how you sit at a desk and things like that. So there is a real opportunity around that as well. And I think that's quite a good lever to get people to invest in this when they know that that costs a lot of money in terms of days of work lost. Thanks, Sue.
Right, thank you. And I'm just, before we bring Andy in, going to take a question from the virtual audience. So this is an interesting one because it's about MSK therapies provided in the private sector. And that's particularly pertinent at the moment because some of the ARMA member organisations who represent a lot of private therapists are saying they are worried because there's a number of people who are coming to see them because they cannot get what they need on the NHS fast enough. And they are really worried about the people who can't afford private therapies and are having to wait for those lengths of time. So this is even more pertinent. But the reality of MSK care is a lot of people will go to an osteopath, chiropractor, a private physio, whatever, sometimes rather than their GP. So we can't ignore this group of people. This is part of a lot of patients' journey. So the question is about, is there a difference between the therapies in the private sector and the NHS, and what does it mean to patients in their recovery journey? So I'm not necessarily expecting you to judge private versus NHS, but where does private provision of therapies in the community fit in the patient journey, and what does that mean? How does that speak to this equalities agenda? Anyone want to come in on that one? Liz?
Yeah, I think it is a difficult one. And I think, we need to embrace everybody who's out there because we need everybody working on this agenda. The difference, I guess, is that the NHS is funded in such a way that we're serving a population where our partners who rely on the income for bringing people in aren't necessarily looking at a whole catchment population. But we need to work together to see how we add value and can use those colleagues there. During COVID, we used the private hospitals a lot to give us the capacity around elective care capacity. So maybe we need to start those conversations to make sure that if we are making the most of what's in the private sector, we do it in an equitable way. But there is, again, that risk that we widen healthcare inequalities by people being forced into using services when they can't afford it, if it'll give them further hardship as well.
Anybody else like to come in on that one?
I have to say, I've never used private physio, but I have been on a waiting list for over a year, so I wouldn't say never. I think we have to be realistic and use what's out there and accept that for some people, that will be the way they go. I do think, though, we have to be very careful, and, everybody in this room will know that, it's difficult for a patient as well, even if they have the money, to know who's going to do them good and who's not going to do them good. So I think there is also that aspect. And also something that not so much in MSK care, you see, but certainly in other services like maternity, you often see the NHS picking up the problems later on of private. healthcare. So, I mean, it is a very complex one, and I'm not quite sure what to do about that. But, you know, I think it's something we have to accept is out there and it's being used, and we have to try and probably work with it at the moment.
Yeah, I mean, I think one advantage of using private providers, whether it's through fee paying or insurance purposes, is the fact that it's timely, isn't it? Yeah. If you can get quick rehabilitation, quick physiotherapy, quick input, then it's only going to make people better. Okay. As a general practitioner, a fair load of my patients can afford physiotherapy, and I often say I encourage it really. If you can get timely input from a physiotherapy, by all means go for it and you can afford it. Unfortunately, primary care is becoming, general practice is becoming difficult in the sense that standard general practitioners as independent contractors are leaving primary care to take up private practice. Okay, we need to manage that challenge really. What are we going to do to stop people doing that? What are we going to do to stop physiotherapists once they've got to a certain banding and level, leaving and entering private practice? Okay, we have to incentivize working in the NHS properly. We need good physical and mental resilience for our staff. If we don't look after them, the NHS will cease to exist as an NHS. I'm trying not to be too pessimistic.
Sometimes quite difficult. Andy, did you want to follow that? Follow that.
I'm just so much easier when you sit behind screens. This is my passive I wasn't going to wade into that question, but I may as well give a bit of a physical answer. So, we've got a massive workforce challenge. Significant challenge. So you've got to think struggle, deal with backlogs, etc. And so thinking creatively is about using traditional energy sources. It's about using non-traditional resources that we perhaps have in the public sector. So I'm very sit next to people, that's coaches, working with the third sector, somewhere, when we do boost our local data, it's trying to do things. And part of that has got to be about working with private sector as well. What we do have to think about is what are the best roles for those particular areas to help to ensure that the system we have is as productive as possible, as high performing as possible. So, do we need to free up capacity for advanced practitioners by providing support for core therapies using different resources, things like that? So we need an overarching strategy about what we need to do differently with regards to that question. With regards to the other question, which is slightly equally as challenging. If we look at where we are with MSK, to be frank, given the burden of disease we know we don't necessarily have resource we like compared to other specialities. There is a focus, I think, and there has been for a period of time, on mortality in the preventative space. And that is not unreasonable because I'll be shot down if I say it is. We could argue that in MSK that we positively impact on mortality long term. But where we really have positive impact is mobility, quality of life. We looked at years lived. We are up there. Back pain is top, MSK conditions are 10. And so we've got to try and flip that focus a little bit, which links with prevention. Now, if you look at Core 20 Plus, which is brilliant, Bo's doing amazing work, but MSK is not on that Core 20 Plus, and I have a problem with that, and I shouldn't be involved in it. But why is that? Well, if we look at the mortality is quite on. obesity, there is a focus on weight management, there is a focus on research, health population, there is a focus on physical activity, because that doesn't really fit in that mortality space. We need to look at that mobility space and quality of life. And there needs to be a locus shift for that, which can then link with the health and qualities challenge, link with what we want to do around prevention. The art of doing that is trying to increase the sort of health policy ladder. It's then by A, aligning to health and social care policy action, B, aligning with operational priorities. At the end of the day, we're not going to work with ICPs or workplace level or with providers if we don't take the policies that they are trying to do. And C, you know, the best MSK health work is a good example of this. Also, training challenge stuff we do, we've got to be opportunistic and make the most of the opportunities that provides a very different challenge to further that MSK agenda. And if we can do those three things and draw away, I think we're likely to have an impact on our vision of cancer. We've got to be really strategic with that. Benefit we have from that pandemic is A, co-production has been this really inevitable from that, and it is around what makes the individual. And B, the level of integration which again is the ability for us to rapidly come together as multiple charities and multiple professional bodies conditions and actions. Because if we do that, we're like an auction place that's cheaper by action, more likely to help us get that agenda.
So, yes, thank you for that. And you mentioned, Chloe, and you mentioned the core 20+5 not including MSK. Chloe has actually asked the question, I wonder what impact it would have if MSK featured in the core 20+5. So I'm just going to make this the last question because we have overrun, partly due to our technical issues. So I'm just going to ask each of the panel members in turn to respond to this issue about the fact that MSK does not get the profile it should have, given the burden of MSK conditions, and the fact that prevention tends to be focused on mortality rather than morbidity, and therefore MSK gets squeezed out. And also, when we start talking about equalities, we don't put MSK up there in that core 20+5 focus. So I'm just going to ask each of the panelists in turn to respond to those points. Asim, would you like to start?
So, I mean, a lot of those core parameters mentioned do impact on MSK. So, I mean, mortality, it's a political hot potato, isn't it? And therefore diabetes, heart disease, stroke prevention, etc., are going to be high up on the list because it's they're bringing votes essentially. Yeah, we have to perhaps as MSK professionals start putting more political pressure on the powers that be to look at the impact, as Andy mentioned, about the physical disability impact of MSK long-term problems. But with my occupational hat on, and as mentioned previously by Liz, the impact of MSK problems on the wider socioeconomic environment is absolutely huge. MSK problems with mental health make up 80 to 90% of days lost for employers. So I think we, again, if we need to start thinking about working differently, we need to start thinking about working collaboratively with partners differently, but also working differently with the powers that be, i.e. the politicians in charge.
Brilliant, thank you. Jane?
Yeah, well, I can't disagree with any of that. I mean, the only thing I would really add to that is, I think MSK conditions should be up there. And one of the reasons I think that is that it does take away so much of people's lives. But also, if we think about multiple long-term conditions, increasingly we're living earlier, younger, with more long-term conditions. And of course, again, if you live in a deprived area, you turn to 15 years, earlier getting those conditions. By the time people with heart and lung and mental health conditions, with very serious conditions, by the time they're 65, half of these people will have an MSK condition. And often it's the MSK condition that really affects their ability to care and self-manage these other conditions. So I speak to people all the time who can't get to appointments for their heart or their lungs or their diabetes because of their MSK conditions. They don't have cars, it's too difficult, it's too much pain, they can't exercise. So actually it is creating, increasing mortality because it's having such a big impact. And I think, that's something we really have to stress because it is a real major issue with other long-term conditions. And unfortunately, that is the way we're going at the moment.
Thank you, Jane. And last word to Liz.
Yeah, thanks. And I have to say, and I probably echo this for everybody that's online, I've heard very little of what Andy said, but I think I got the gist of it. And I would say, don't beat yourself up that MSK is not one of the 5 clinical conditions. The core 20 plus applies to everything. So I would throw the challenge back and say best MSK, ARMA and everyone need to be a lot better about working with and engaging with people from our most deprived communities, making sure that all the data and metrics that we're producing that are going up onto model health system and how we collect data in primary care and community settings is able to segment data and stratify it by deprivation, by ethnicity, by people with learning disabilities and severe mental illness and other inclusion health groups, so that we're in a really strong place to know just where we are and to measure impact in what we're doing. So I wouldn't say that's a limiting factor. I say let's go for it and apply that core 20 plus sort of framework to what we're doing. We don't have, a specific target around those 5 clinical areas, but it's not going to hold us back on really moving forward on this agenda going forward.
Great. Thank you very much, Liz. Just going to stop the recording. Stop. So